Rahman is there. Harun ki join course. Is the Harun is there? Dr. Harun?
Join.
Yes, okay. Okay.
Hi, Miss.
Good evening.
Hi, Mr.
How are you?
All good.
Hello. Good morning.
How are you?
Good,
Yeah.
sir.
So I think we have everybody except Dr. Soosan. Sir, we are 7:30, so I think we can start and let her join us.
Okay.
Okay.
I will share my screen and is my screen visible?
Yes.
Okay, thank you.
Yes, it's in the stream.
Bangladesh Eye Hospital and Institute is going to organize a series of webinars on ophthalmology. Ophthalmology Webinar 2020 is 19th and 26th of June and 4th, 10th and 17th of July 2020 at 7:30 p.m. Bangladesh Standard Time. Big names, great surgeons, passionate teachers, creative innovators, supportive peers of ophthalmology will be speaking on current trends, topics, managing difficult situations about their innovations. Join the webinar where you will have the chance to hear their thoughts, clarify your queries, and know what goes in their heads and minds.
Thank you, dear colleagues, for joining on different platforms in the webinar. On behalf of Bangladesh Eye Hospital and Institute, I welcome you all. And before we start, I want to thank all the speakers and the panelists for accepting the invitation. And thanks to Aristovision for helping this webinar broadcasting part. Before we start, I want to introduce shortly our speakers today. We all know all the speakers, they are just the stars of refractive surgery. We all look forward to hear them different conferences. I'm to introduce Mr. Mohammad Rosman. He is the senior consultant and head of refractive surgery service and laser vision center in Singapore National Eye Center. And he is the adjunct associate professor in graduate medical school, Dukes, National University of Singapore, and adjunct senior clinical investigator in Singapore Eye Research Institute. He is the senior lieutenant colonel at Singapore Armed Forces, and he has been invited all over the world in national and international conferences to deliver his presentation, and he has more than 40 publications, and he is author of many chapters of books. Professor Rohit Shetty, he is a cornea and refractive surgeon consultant, and he is the vice chairman of Narayan Netralaya. He is the clinical and translational scientist in GROW Laboratories. He is the faculty of Department of Ophthalmology in Maastricht University. He has got more than 200 scientific publications, and he has been awarded the Casper Award of ISRS in 2019. And we all know that he has got a PhD, and he works behind all these instruments also that we use in the different refractive surgeries for assessment, and he will be talking on that too today. Dr. Soosan Jacob, she is the director and chief of Agarwal's Refractive and Cornea Foundation and senior consultant of cataract and glaucoma services in that hospital. She is the chair of the International Society of Refractive Surgery, a partner of the American Academy of Ophthalmology, and she is the ex officio of ISRS Executive Committee. And she is in many of the editorial board of Journal of Refractive Surgeons, International Indian Journal of Ophthalmology, and many other journals. And she is in the advisory board of American Ophthalmology INET. Professor Germán Roberto Bianchi. He is the professor of ophthalmology in University of Buenos Aires, and University of Moron of Argentina. And he is a anterior segment and refractive surgery and chief of cornea transplant services in Clinica Nano of Argentina. And he is invited speaker in different part of the world, and he has authored scientific papers, book, chapter, and peer-reviewed international journals. Dr. Maziba Rahman Chowdhury. She works as a consultant in Bangladesh Eye Hospital and Institute, and she has a fellowship-trained refractive and cataract surgeon. She is a speaker in national and international conferences, and she was so keen to do refractive surgery. She has gone to work under Professor Rohit Shetty, and he is a budding star of refractive surgeon in Bangladesh. And I will be today's moderator of the session. And this is going to be live streamed in YouTube and Facebook. So if you have any questions, please put your questions in the QA. And if you have any other issues like sound or any other thing, put it in the chat box. All the speakers are going to be available at the end of all the presentation. We are going to have the question and answer session. So I would invite Dr. Roseman to share his screen and present. I'll stop sharing mine.
Oh,
Dr. Roseman.
Thank you so much, Istik. Let me just start off. Okay, firstly, I'd like to thank Dr. Ishtik and my colleagues from Bangladesh for inviting me to speak today. I understand from him many of the eye doctors in Bangladesh, ophthalmology in Bangladesh, are interested in refractive surgery, but they have not started. So some are about to begin, some are interested. So therefore, my talk is, I was asked to talk about pre-LASIK assessment for beginners, so that if you do come across any patients that you think are suitable for refractive surgery, you know how to examine them, what to look out for. And in future, if you become a refractive surgeon, this will be very important for you. So just to start off, I think we need to know what is an overview of refractive surgery. So refractive surgery, although my title is about LASIK, refractive surgery is not just LASIK. You know, we know that there are the keratorefractive surgery, and this includes surface ablations. For those beginners who may not be familiar, this involves lasering directly on the cornea after removing the epithelium. And this group includes PRK, LASIK, which involves the use of alcohol, epi-LASIK, and also trans-PRK. LASIK, which many of you may be familiar with, involves a two-stage surgery, one creating the flap, either using a microkeratome or femtosecond laser. The second stage involves using excimer laser to change the shape of the cornea and then replacing the flap. And SMILE, which later I think one of our speakers will be talking about, is a newer technology where it involves removing the lenticule from the cornea. And of course, for those with higher degrees, they may require the use of phakic intraocular lenses, which again will be discussed later. Other than that, refractive surgery that also includes cataract surgery. Refractive cataract surgery includes also presbyopic surgery. But today my talk will be focused mainly on how to assess a patient who you think is whether he's suitable for LASIK or what other surgeries are suitable for this patient. So these are some of the reasons why people choose to go for LASIK. Majority of the patients are for cosmetic reasons, some for functional reason, either their lifestyle, their sports, some for therapeutic reasons, for example, anisometropia, or if they are unable to tolerate contact lenses or glasses, or because of refractive error resulting from other eye surgery. So for assessment of suitability for refractive surgery and LASIK, in general, the principles are similar, but I'll focus more on LASIK. And I used to remember this simple acronym, no specs, which simply when you look at a patient, you think about whether he has normal eyes, what is the patient's occupation, the stability of the refraction, pregnancy and breastfeeding, expectations, cataract and contact lenses, and systemic conditions. By knowing this, you should be able to cover most of the assessment. So just to elaborate about normality of eyes, when you examine the patient, when you think about whether the patient is suitable for LASIK or any of the refractive surgery, you have to first decide, look at whether the patient has any significant ocular disease. In particular, whether any of the disease can interfere with the LASIK procedure, for example, severe corneal scars, vascularization, any of the conditions that can delay healing, persistent epithelial defects, very dry eyes, or those that can interfere with outcomes, or those that has association with certain complications. For example, we need to exclude keratoconus and other corneal ectatic diseases. Also, sometimes we have to decide whether we want to do surgery in a patient who is only one eye, because if anything happens, that is the only eye for the patient. So in patients with one eye or very dense amblyopia, we may have to really consider carefully whether is this patient suitable for refractive surgery or not. So for example, a lot of contact lens patients has loss of this vascularization. This can interfere with your surgery. So it's something that you want to look out for. Scars, this can again interfere with the LASIK. May not be suitable for LASIK. You may want to choose either for small scars, maybe we can consider surface ablations. For this kind of dense scars, maybe phakic intraocular lens will be a better option. Those with dry eyes have to be treated first, or we may want to consider non-flap related surgery like surface ablation for such patients. Eye measurements, we have to really know the refractive error of the eye, have to have a very accurate measurement of the refractive error. We need to know the thickness and the measurements of the eye, and that's where topography and tomography comes in. I understand from Dr. Ishtik that most of the hospitals in Bangladesh uses Pentacam, which is what we used to. And so this is crucial in all pre-assessment. You have to do either a topography or tomography. And the Pentacam is currently most widely used in most centers. And I'm not going to talk in detail about this because there's a lot to talk about. I'll just go quickly on what I look for. I look at the SIM case to make sure there's no extreme astigmatism or high case. I look at the cornea thickness, it's important. Look at the thinness pachymetry, as this will determine whether we can proceed with LASIK or not. I look at the white to white to determine on for those using microkeratome, the foot plate, and for those using femtosecond, the size of the suction device, pupil size to determine the size of ablation zone, and of course, most importantly, to make sure there's no signs of keratoconus or form thrust keratoconus. So features of keratoconus, I will not elaborate. As you know, there are many features. Paracentral thinning, apical protrusions, and so on. But what is more important is probably the form thrust, where it's easy to miss out. In some cases, like in this case, it can look very normal, but if you look closely, although the pachymetry is normal, you can see this very steep high K, the posterior elevation is raised, and in most Pentacam devices, we have indices to help us. Like in this case, you can see that the indices is, the BAD is grossly high, and there's severe signs of posterior elevation. Other than the physical aspect, we need to consider the holistic aspect of the patient. What is their patient's occupations? Do they have very high visual requirements, like pilots, engineers? In this case, we have to really discuss with them on their expectations, because in certain cases, there is always risk, and there's always a possibility of loss of best corrected vision. In patients who does a lot of active sports, high chance of significant trauma to the eye, we may have to consider flapless surgery. So SMILE or surface ablation may be a better option for these patients. In terms of the refractive stability, I think it's very important. Age is a consideration. However, age is not the only consideration for refractive stability. Some centers will take 21 years or older as a minimum cutoff, and some centers may take 18. The older the patient is, the more likely the patient will be refractively stable. And why is it important? It's important because if the myopia is not stable, you may have to repeat the surgery or do enhancements over the years. So one way to assess the patient's stability is to discuss the patient on the myopic progression. Some patients know, in general, if their myopia is increasing by 0.5 diopters to 0.1 diopters a year is considered as not stable. Anything less than that, I think it will consider as relatively stable. And of course, you can look at their previous prescription, their spectacles or their contact lenses to decide whether they have progressed over the past few years. And of course, for those who are above 40, presbyopic considerations is very important. You have to discuss with them about presbyopia, the fact that they may require spectacles even after a successful LASIK or refractive surgery. For ladies, is again important to take a history on whether they are pregnant or breastfeeding, as this will result in a possibility of unstable refractions during the pregnancy or lactation. And of course, because of the altered healing response, it can result in instability in the refraction post-operatively. General advice is to wait at least 6 months after birth or 3 months after cessation or breastfeeding and return of menstrual cycle before performing corneal refractive surgery. Okay, I think expectation is very important. I think to have a successful surgery, we have to meet the patient's expectations. And if the expectation is too high, there is a problem, because we cannot guarantee in all patients that they will achieve 100% results. So I think realistic expectation is important. We have to explain to the patient about the aim of refractive surgery is to reduce refractive error and to improve unaided visual acuity. And in some cases, patients may still require glasses, especially for presbyopic patients, or in some cases for dim light or night driving. So be very careful when you hear patients saying that they want supervision, they expect 20/20 vision, they want to see better than before, or they had friends who had LASIK and had 6/3 vision, 6/4/5 vision. So I think you have to temper the expectations in these cases. My mentor always says, it's best to give low expectation but over deliver. Okay, and examine the eyes very carefully for presence of cataracts, especially in patients who are above 40. Nowadays, we are seeing younger patients with cataracts. I've seen patients who are 40 years old with cataracts. And this is important because if they do have cataract, I think refractive surgery may not be the option for them. A cataract surgery is a better solution because the degree of refractive error may change over time, and it's difficult to achieve good refractive outcomes with early cataracts. And also for those with contact lens, before you do an examination, especially before you do a topography or tomography, the patient should stop contact lens for at least 1 week for soft lens and 2 weeks or more for the rigid gas permeable lenses, as this will affect your results of your tomography or topography. Okay, other than ocular conditions, we have to rule out certain systemic conditions that can affect the surgery, in particular autoimmune disease. Some autoimmune diseases are known to affect the cornea, like RA, SLE, and poorly controlled hormonal diseases like diabetes, keratoconus may affect the refractive stability. So I think it's important that it's not an absolute contraindications, but they have to be controlled first. Some drugs like Roaccutane, we have to stop the drugs as it may affect the outcomes of surgery. And of course, the patient have to be able to give informed consent and able to cooperate during the surgery. As you know, LASIK is topical anesthesia. The patient have to cooperate. If not, you won't be able to proceed the surgery. So in doing LASIK, we have to take into consideration the refractive error and the cornea thickness proportion. In general, I would not do myopia if the myopia is too low, less than -1, but I do in some cases. What is important is the upper limit of correction determined by the laser use and the minimum corneal thickness. The thicker the cornea, the higher the myopia that you can correct. And this cornea thickness is predetermined and varies from person to person. So if your cornea thickness is insufficient, you will have to consider other types of refractive surgery like surface ablation or phakic intraocular lenses. So these are the contraindications: unstable refractive error, too young a patient. As I said, some countries may take 18, some take 21. If the cornea is too thin, if they're pregnant, they have autoimmune diseases, or they have pre-existing eye diseases, especially keratoconus, active corneal diseases, severe dry eyes, cataracts, and other diseases that can affect the vision. These are contraindications. So I think for those of you who are starting out, if you intend to do LASIK or any refractive surgery, I think these are the best patients for you. Of course, you take a patient with normal eyes. Moderate myopia is the best because the predictability is highest. Those with low astigmatism, age between 25 to 35, because the refractive error is usually quite stable and they do not have presbyopia. Females tend to be much more happy with the results usually. That's what I see. And those with type B personality. So if you were to choose a first LASIK patient, this is the kind of factors that you look for on top of all the other things that I've discussed just now. Thank you so much for your attention.
Thank you, Dr. Roseman. That was an excellent presentation. I'm sure that we're going to have a lot of questions. And rightly said that, we should not promise too much, rather deliver more than whatever we commit. Now I would like to invite Professor Rohit Shetty. So can you please share your screen? Unmute please also.
Can you hear me?
Yeah, we can hear you, sir, but we can't see anything. You have to share the screen.
1 minute. I think. Let me show here. Yeah, I got it. Now, can you see the screen?
You have to go full screen. Yeah, perfectly. We can see it, sir.
Is it better now?
Yeah, it's better.
Thank you. Thank you, Dr. Anwar, and all my friends from Bangladesh, and also from the Bangladesh Eye Institute, and the co-panelists and the co-speakers. It's a great privilege, an honor to be presenting in front of this audience. My talk today is about the newer diagnostics opens up understanding to refractive surgeries. These are my financial interests. I do some research with these companies, but it's not going to affect what I'm going to present today. We are all in this kind of a situation now. We used to all meet in different meetings, and I was there in Bangladesh last year, maybe at the same time. And it's like an old story now. I think we've really gone to this new understanding of new normal of this webinars. Dr. Roseman has already spoken a lot about beautifully about the different types of indications, but I'm just going to stick to only about the instrumentations. We started with just a refraction to today we are looking at the biomechanical assessment. But still there are a lot of challenges, topographies like this, and your quality of vision, patients going into ectasia. There's a lot of challenges for a refractive surgeons. So what happens is your old ways will not open new doors. We'll have to find new ways, and we had to unravel the hidden mysteries. This is a beautiful photograph of all of you who are used to reading Jungle Book. This is a Bagheera and this is a black panther, very rarely seen. This is something close to where I stay, around 200 kilometers. And there's a beautiful photograph by a National Geographic National Geographic photographer of Bagheera. So I'm going to look at a new perspective understanding refractive surgeries. Let's start with tears and optics. See, one of the most important thing is we've always been told that the tears are a very important optical surface, but it is very difficult to quantify how much of it is really quantifiable. So we are looking at now using an optical quality assessment system, analyzing the optical quality of your tear film and seeing how it affects your quality of vision. That means virtually all refractive surgery, multifocal surgeries, everything has a huge impact on your tear film. For example, this is a normal eye, and this comes as OSI. OSI is the optical scatter index, which is normal. And you can see here with the dry eye, you can see that there's a lot of scattering of your tear film. And higher the OSI here means your quality of your tear film is bad. So this is what happens from your first blink to the time you blink again. You can see that there is a huge amount of scattering of your tear film optics. So if it's a stable, then it should be, a whole of this tear film should be in the green zone. So if it becomes down, it means your tear film is creating a mess. This is very important, especially when you are working on your multifocals and many other instrumentation. For example, if this patient has a very, very unstable tear film, and this could be one of the patient who is your multifocal unhappy patients, and he complains of glare, and the glare is because of your tear film, and here it's completely stable. So what I'm trying to say is technologies like this for a refractive surgeon helps us to understand the importance of how a tear film itself could be a very important factors, which we sometimes miss. This particular patient may have had a very bad ocular surface, and his quality and his glare is because of a poor ocular surface. And this ocular surface also has a huge impact in your depth of focus. And that means if you have done a refractive surgery, the patient depth of focus is bad, this maybe could be related to your tear film. So from the ocular surface, we go into the second layer, your corneal nerves, and you need confocal microscopy. And these are your corneal nerves, the subepithelial nerve plexus, the beautiful nerves which has its own branching, and this is how you analyze them. But these are healthy ones, and these are unhealthy. And these things are your dendritic cells. These are inflammatory cells. They are your Langerhans cells, which are quieter, which comes to the center, and they create a lot of problems. And we published this work. When you have a lot of these cells, they create, patients have a lot of sensation. If you're speaking loudly, the patient may have eye pain. So that means that even they're very sensitive. And this is what confocal shows. It is very common after refractive surgery. And how does this impact your refractive surgery? Let's look at all the patients here, the healthy nerves and unhealthy nerves. And these are all your pre-op patients. And you can see that epithelium itself is extremely irregular when you have an unhealthy nerves. And many times we just do this refractive surgery because the patient wants to get rid of glasses or contact lenses. And what really happens is the patient who had a poor nerves has poor healing. And you can see that the healing is good here, ordinary, and this is bad. So what it means is preoperatively, if your nerves are bad, your healing is bad. And what really happens is, this is very important. This is something completely new emerging ideas. Your nerves and epithelium have a very nice hemostasis. When you have a poor healing of nerves, your epithelium is also very bad. So what it does is it creates very bad quality of vision. And this is all normal. So all your epithelium is good. And look at this. And look at the preoperatively, these are all healthy ones, and all of them are unhealthy ones. They're all dry eyes patient, and you can see that how important it is to understand the epithelium, nerves, and tear optics in your understanding of your refractive surgery or any surgery you do for your matter. So this is important because many times we blame, if you do a surgery, something doesn't get well, you blame your lasers, you blame this, blame that, blame your multifocal. If the patient has this kind of a cornea, and this kind of a thing, and you do a multifocal on him, you will still end up with this kind of an epithelium and this kind of an epithelium. And what would happen is you would have a scatter like this. And look at this tear film here. It's all over the place compared to this one, which is perfect. And this is decent, this is bad. So what I'm trying to say is it's a huge balance between multiple things out there. And if your balance is not there, then you end up in terrible mess. And this is going to be the factor which you need to keep in mind in this new normal. So what happens with the short healing is a perfect vision needs a perfect tear film, like I showed here, a perfect epithelium, and a perfect nerves. And this is what is important to get you a perfect outcome. A poor epithelium, a poor epithelial healing, and a poor nerves, no regeneration. This is a recipe for disaster. You can get the best of machines, you can do a smile, you can do a LASIK, you can do PRK, you can do whatever you want, but this is the whole problem. This is how a healing happens. And we have seen that when your nerves don't heal, even if your topography is normal, in 3 to 6 years' time, you end up with ectasias or corneal haze. The corneal haze is not always dependent on your lasers or mitomycin. Sometimes you use mitomycin, still you get haze. That's because your nerves were not healthy at all to begin with. And nerves, there's a huge amount of hemostasis balance out there. And coming to the second point is that about talking about the epithelium, these are the kind of topographies we do. And many times we discuss, should we do a laser or not? Because we are not seeing this as a whole. So it's like this picture here. We are supposed to look at the stroma, but what we are seeing is from your epithelium. So the epithelium is like a well-fitting dress. It masks everything. So what's the true picture? We did some work on OCT-based topographies looking at the Bauman's layer, but there's a new tool here called MS39, which is from Oculus. I don't have financial interest, which dissociates the epithelium, stroma, and the stromal structure, the epithelium structure. It dissociates virtually everything. You can see that it's a huge amount of dissociation. I call it the true revolution in topographies because this is what the topography should be in the future, where you will see an epithelium, and this is how it is. You see the anterior elevation, and you see the stroma that is without epithelium. It is virtually subtracted epithelium. That means if you see a topography like this, you know what is the anterior elevation, you know what is without the epithelium there. That means it virtually subtracts it. So let's look at some example. Is this a issue with the topography? And now we can see that this patient has an epithelial change here, and the topography pentacam is showing it as an elevation. You would call it as an FFKC and you would not do a surgery. But look at this, the exact same point, there's an epithelial hypertrophy, but the stroma, all greens means it's normal, and there is no elevation at all here. That means this patient is a perfect one, even though it looks suspicious, because the pentagram will not give you the stromal changes. But what are you interested in? You're interested in the stromal changes. You're not interested in your epithelial ones. And this is exactly, and this has a huge application in keratoconus. For example, if you look at this, this is a progression. If I ask Dr. Kamrul Khan or Dr. Rashid, both of you agree that we'll do we'll do a cross-linking on this. But look at this. And you can see that the epithelium has changed here. And you can see that the stromal changes also has changed out here. And we know there's a change. But look at this patient. This patient also is in progression. But look at this. The epithelium was thin here. Now it has become 65 microns. So this is just an epithelial hypertrophy, not actually a true progression. So this patient is actually stable, is not changing at all, even though you can see that this epithelium has changed from 49 microns to 65 microns. This is actually a 1.5 diopters of change. So all this is going to be, and your stroma is exactly the same as it was a year back. That means you're looking at the stromal level, not at the epithelial level. And this is exactly the same thing. The cornea was thin, now it has become thicker. So that's why you see a progression. These are all stable keratoconus. And you can see the stroma, there's absolutely no change. And this is what I feel is going to be the changes. There are a few more slides on the biomechanics. Now your biomechanics have different waveforms. There are a lot of mathematical ratios out here, which tells you multiple things. And now this is all there in the compute in the pentacams. It tells you all these things, and it gives you both the biomechanical, which you call the CBI and TBI. It's a little confusing, but when you start using it, you know, it's more of mathematical driven out there, and there are a lot of cutoffs for this. There's a new index called stress strain index now. Anything more than 1 is good. And you know, when you have a less value, that means the cornea is weaker. And this is one interesting feature here. You can see that it tells you if you are doing whether it's a softer eye or a stiffer eye. So you can see that if your eye is softer, that means you are not a very healthy eye. And after you do a cross-linking, sometimes it actually becomes stiffer. For example, you do this is one patient, it became stiffer after you're done with the cross-linking. And this is very interesting because you know that the cross-linking is working. There are a lot of new things which is happening out here. So what are the future? Being a cell biologist, I do a lot of my work linking both the mathematics and also the cell biology. We've been trying to build our own OCT to image the collagen. This is the polarization sensitive OCT, which is trying to look at your collagen. This is how a collagen looks of a OCT. We are trying to see this is how a normal should look. A good collagen here. There's a peripheral collagen here. You can see there's a dropout of collagen here. And in KC, you hardly see a collagen. So this machine, what we have built, it's not a commercially available, which is built on our own lab, which tells you how a collagen is actually seen. So what happens is tomorrow, along with your OCT, you will also probably use this to see how the orientation of collagen, because based on this, you can see whether your cross-linking is working, or you want to do an extra, or you want to do any of the procedures. For example, you see there's some suspicion out here, and you can see that there's a full loss of, I mean, this is normal. This is how a normal should look. And you can see there's a loss of signals from the collagen. So you hardly see a collagen. So this is going to be the revolution in how a refractive surgery will be. We actually will be able to see the collagen. And we are building a lot of diagnostic kits. These are some of our papers where from the tiers, we are looking at different parameters to see. And this is how we are doing. If not for COVID, we would have had this machine out. Now, all the people working on these kind of technologies are all gone into building kits. So we are a little bit of issue there. So otherwise, we would have looked at all the inflammatory parameters. To sum up, what I see in the future is mix of beautiful imaging technologies like the MS39 or Pentacam, and you're looking at the collagen directly. You link it with the molecular signatures. Now, how you have the COVID test, I think you can do a lot of, even COVID thing also can be done from the tiers. If you put our efforts into it, I think this is a new wave of thing, and this is what is going to give you the true picture. I thank the entire fraternity of Bangladesh Eye Hospital and all very good friends out there for giving this opportunity. Thank you.
Thank you, Professor Rohit Shetty. Thank you so much. You are always, coming up with the new things and giving us new ways to detect everything earlier. So I think it's my turn now. I'm going to share my screen, and I will be talking on LASIK. Is my screen visible?
Yes.
Am I visible? Okay.
Yes, you are
visible. You can carry on.
So, LASIK is the most commonest performed out of all the refractive surgery. And just to get an idea that in 2019, there was 700,000 LASIK performed worldwide. And in USA, since it started, more than 10 million person has undergone LASIK surgery. So it is a small form saying that laser in situ keratomeliosis. That means that we use laser in the natural position where the cornea is to reshape the cornea so that the rays coming from any object is focused on the retina. And we all know that the refractive error are on a rise, and the current trend to treat this refractive error at the glasses, contact lens, and refractive surgery. And the glasses has got its own limitation, we all know, and the people who are wearing them know better than any of us, I think. And also there are some risk associated with the contact lens. So what I tell to the patient that LASIK is a very simple 3-step surgery. first we have to create a flap and lift it, and then reshape the cornea with a laser and put back the flap that was created in the first step. So these are the 3 simple steps. So the corneal flap can be created by a blade or a femto laser. Then excimer laser is used to reshape the cornea and reposition of the cornea, which was created at first. So first I'm going to show how a blade is used. So once the eye is stabilized using a vacuum, a very sharp blade oscillating moves on a specific depth over the cornea. And so a flap is created. And the flap thickness can be varied according to the blade. So this is as simple as that, as creating a flap with a blade. But this is what we do when we are using a femto laser to create a flap. A patient interface is comes down on the patient's cornea, and it's just a little pressure that patient feels, and then the laser makes a cut in the cornea, which is very controllable depth, and the diameter is easily whatever we want to, we can make it. So the benefit of a femto flap over a conventional flap is that the flap thickness, flap diameter, side angle cut, hinge position, hinge angle, we all can alter this according to the need and as we wish. So once the flap has been created, we just lift the flap, and the flap created by a blade is very easy to lift in compared to the other one, and then excimer laser is applied and the bed is washed and the corneal flap is repositioned. So this is just the surgery. But with a femto flap, what happens that this is little sticky in comparison with the blade one. So we have to separate it manually. As this does not cut, the laser uses pulses to separate the tissue. So we have to go very slowly. And this is why Dr. Roseman was saying that patient has to be cooperative. This is under topical anesthesia, and certain amount of cooperation is needed from the patient. So the iris registration is done and excimer laser applied. And we can see that it took only 12 seconds. This was something like 5.5 diopters. And it's a very short procedure as such. And then we put back the flap, wash the eye, and the surgery is over. So as we were talking initially that there are only few surgeons in Bangladesh that they are doing, and still the use of LASIK or other refractive surgery is growing, because there are some myths about the surgery that's still new. It hurts a lot, and if you blink or move, it's going to go wrong. Something can happen to our eyes. I'll just be very brief on this, that it started in 1961. Dr. Jose Barracar used it first in 1961, and it has gone through many revolutions, and in 1999 it got FDA approval. That means that it's nearly more than 20 years over that LASIK was started. And it does not hurt. We only put a anesthetic numbing drops to do it. And regarding the eye movement and having some problem, is that there are a lot of sophisticated eye trackers. There are so many lights that this just follow the eye. So if the eyes are moving, the laser will also move. And there are these blinking lights that the patient only has to look at that. And we just tell the patient that there is the green light, this is the laser going on. So patient just has to look at the green line for not too much, 10 or 20 seconds. And this is an external view of showing that how the eye is tracked. So that thing comes down, tracks the eye. We can see that there is a live eye tracker which is tracked on the pupil. So a little bit of movement the laser is going to follow that and no harm is going to happen. So in conclusion, I want to say that LASIK is not for all eyes. So there are certain amount of pre-LASIK assessment that we do, as Dr. Roseman and Professor Shetty has already mentioned, but it is a very safe surgery when carefully evaluated. It's very effective, and with all this technology, this is going to be a very good thing in future for us. And with that, I want to thank. So all these speakers are going to be here. If you have any questions that could not be answered, just keep me a mail. I will try to answer them. Thank you all. I will stop sharing my screen. I would request Dr. Maziba. Maziba, can you share your screen? And she's going to be talking on PRK.
Is my screen visible?
You're visible and we can hear you.
Okay, thank you. Then I'll start. Good evening to you all. It's an honor to be present among some esteemed speakers. So I'll be talking about PRK. PRK surgery, it had lost its popularity in the 90s. So we are going to be specifically discussing the factors which are responsible for the rebirth of PRK. What is PRK? It is also a type of refractive surgery, photorefractive keratectomy. Its difference from LASIK is, in LASIK, what we are doing, we are creating a flap. Over here, instead of creating that flap, what we do is we remove the corneal epithelium entirely. There are different methods of removing the epithelium, which we will talk about later. After the removal of the epithelium, then the second part is the same as LASIK. Excimer laser ablation of the stroma is done in order to correct the refractive error. Once the procedure is complete, we put in a therapeutic bandage contact lens in order to facilitate the epithelial healing. Let's look at the factors for what it lost its popularity. In patients, it caused pain, severe pain, and in many patients came back with haze. Due to these are the main factors for which doctors stopped doing PRK. But there is a role of PRK still in our refractive practice. Why is that? In case of thin cornea, or in case of any suspicious topography, where I would like to save some stromal tissue, then PRK could be our surgery of choice. And also in suppose sports personnel or military personnel, where I would like to avoid any flap related complications, I can also go for PRK. But how much correction should be done? It's said that we can correct up to myopia minus 12 diopter, astigmatism up to 6, hyperopia up to 5 diopter. But what the point I would like to emphasize here is that in our practice, we have seen that PRK works best in case of lower range of refractive error. And we do myopia correction up to maximum up to minus 6 with or without astigmatism of 4 diopters. We'll look at this patient. He had come for a refractive surgery. He had a refractive error of minus 5. The corneal thickness was 475. So this patient, we thought that this would be an ideal case for PRK, and we had opted for PRK for both eyes. And he's doing very good now. Before going to the surgery, I will want to say that how we have tackled those issues, the pain and the haze. I'll be talking about the pain first. I'll be sharing a video over here. This is the protocol that is followed in Nara Netralaya, and this was done under the leadership of Professor Rohit Shetty.
PRK is a wonderful surgery with many advantages. So why did it go out of vogue? Was it due to the problem of postoperative haze? In the survey we did, most doctors were against doing PRK due to the postoperative pain. So we thought, what if we could reduce this pain? Would this procedure be more acceptable? We did a quick search on Google for commercially available painkillers and found a preservative-free option of ketorelac called Acuvale. We used these drugs topically after surgery and noticed that the Wong-Baker pain scale changed from 8 with no analgesic drops to 6. This decrease in pain was not enough. So we wondered if we could perhaps prolong the action of Acuvale by using it in a depot form. Topical drops would wash out of the eye within minutes, but the depot would maintain the concentration of the drug for longer. To begin with, the bandage contact lens packet was cleaned with alcohol. We then waited for 5 minutes. 0.2 ml of AccuVeil was injected into the BCL package. The bandage contact lens was then allowed to soak in AccuVeil for 20 minutes, following which it was placed on the eye after PRK surgery. The Wong-Baker pain scale this time decreased from 8 to 2. We had many questions in our minds about the ideal time for BCL soakage and the period of time the drug would continue to be released from the contact lens in therapeutic concentrations. So we performed an experiment where the AccuVeil soaked bandage contact lens was placed in an Eppendorf tube and then transported to the laboratory. The contact lens was then subjected to high-performance liquid chromatography, which helped analyze the concentration of AccuVeil at various time points. This chromatogram depicts the concentration of AccuVeil at different time points, and it can also be seen that the drug reaches its peak in 1 hour and it maintains that concentration over the 6 hours tested. To answer the question of why to clean the bandage contact lens surface, we did a laboratory experiment where we took a swab from the alcohol-cleaned bandage contact lens surface and the unclean surface and cultured the same. We found that there was growth seen in the uncleaned surface. We did a study which included 70 patients divided into 2 treatment arms and the use of the Wong-Baker pain scale. The first treatment arm included thoroughly washing the eye with cold BSS and placing a regular bandage contact lens after PRK. The second treatment arm included washing the eye with cold BSS and placing a BCL soaked in AccuVeil over the eye after PRK. We found that in Group 1, the Wong-Baker pain scale was around 8, and in Group 2, it was around 2. Pain after PRK can be a huge challenge, but it can be conquered.
So we have seen that it's a wonderful way that we can control the pain. Now let's come back to the haze. For haze, first we need to understand what is the cause of the haze. Yes, there is the amount of strobel ablation done is one of the main causes of haze. But apart from that, we have to see what is the eye. Is the eye quiet? Is the eye inflamed? Because an inflammation in the eye may lead to postoperative haze. Thinking this, again, what we do routinely for all patients, we give the OSDI form. In that, we can see that what is the condition of the eye. And if the OSDI score is higher, what we do is preoperatively, we go for topical steroid and for capsule doxycycline treatment in order to quieten the eye. Paraoperatively, as we all know, what we do is we are using MMC 0.02%. It helps to reduce the myofibroblastic activity and thus reducing the haze. There are many papers which shows how much MMC should we use. I'm following the Narayan Netralaya protocol. What we do is for low error, we do not use any MMC. But from 3 diopter onwards, what we do is we use MMC for 10 seconds per diopter of refractive error. Now let's come to, as I was saying, that there are different methods of removing the epithelium. So the first method that was actually used routinely was that it was mechanically debride from periphery to the center. But even in expert hand, it might lead to nicking of the Bowman's membrane. So we have to be careful. The second very common method that was been used, that we give 20% alcohol, we keep it for 15 to 20 seconds. What it does is, after that, we can see that the epithelial can be removed very easily. But from now, what I'm doing is, instead of alcohol, if we put in proparacaine, and again, we will see that the same way the epithelial can be removed easily. And after that, the excimer laser ablation is done. Next, I'll be talking about Streamlight PRK. I don't have any financial interest here, but mainly the machine available in Bangladesh is EX500. So I'll be talking about this. What Streamlight PRK does, as I was saying, it uses laser to, at one go, at one step, at first it removes the epithelium, and in the same step, what is done is second, it causes the stromal aberration to correct the refractive error. So at one go, the whole surgery is complete. So we can say that this is more neater, and maybe because it's more accurate, it might lead to post-operative better healing, wound healing. And I'll just show the whole surgery here. Because the refractive error was 5 diopter, I have put in MMC. And after the MMC, a thorough wash with BSS was given. And once the wash, I know it's complete, I will put in the therapeutic contact lens, which I'll keep for 3 days to help in the epithelial wound healing. So now the question comes in mind that there are so many techniques to remove the epithelium. What to do, what to use. So there are many studies, but most of the studies comes to the same conclusion that whatever method we use, if we see the criteria, that is safety and visual acuity, most of the they have similar results. So whatever work in our hands, we can go ahead with that. And now, by using the above discussed protocol, I think we can safely put in PRK in our refractive practice, and we can start this by correcting myopia in thin cornea. Lastly, the question comes in mind. So which is the best surgery? I want to end by saying that there is no best, because each surgery has its own merits and demerits. So now that we have so many options, what we can do is when the patient comes, we can actually hit and give the spot on treatment to the patient to give the best outcome. Thank you.
Thank you, Maziba. That was an excellent presentation. Now I would request Dr. Soosan Jacob. Dr. Soosan, can you please share your screen and unmute?
Hello?
Yeah.
Yeah, I'm doing that. Okay, can you see my screen now?
Yes, we can see it.
First of all, I'd like to thank Dr. Anwar and the Bangladesh Eye Hospital and the Bangladesh Society for inviting me here for this talk. You've got a very good lineup of speakers from Bangladesh and international, and I congratulate you for that. I'm also happy to see my friends from Bangladesh, Dr. Maziba, Dr. Anwar, Dr. Haroon, and Dr. Kamrul, and all the others who are probably also online. And I'd like to say a very good hello to all of you. So my talk is going to be on SMILE, or small incision lenticule extraction. And we know that this is a relatively more recent technology that has come into the refractive surgery market. And basically, if you consider cornea-based refractive surgeries, we know now from all the nice talks that have been given that refractive surgery cornea-based can actually be divided into 3 types. One of which is surface ablation, which is what Dr. Maziba also talked about, and which includes PRK, LASIK, and EpiLASIK. You then have the LASIK, which is basically, it uses 2 lasers. It can use 2 lasers, which is a femto-LASIK, which includes the femtosecond laser and the excimer laser, or you could make a flap with a microkeratome, which is a mechanical cutting device, and then you could go on to excimer laser for the ablation. And the third type is the relax SMILE, which has 2 types, flex and SMILE. And flex also involves creation of a flap, following which a lenticule is removed, whereas SMILE is flapless and all femtosecond, and these are a single step surgery. So when you talk about small incision lenticule extraction, this is basically in one way a refinement of the LASIK technique. What is done is basically that an intrastromal lenticule is cut, and so it's like having a lenticule that corresponds to the refractive error that the patient has. This lenticule is also cut with a femtosecond laser, and it's removed through a small incision. Now, just to show you a video of the procedure, this was a live surgery that I had done, and you can see that there are 2 cuts. This is the anterior cut that's being dissected, followed by the posterior cut also, and this finally separates a lenticule. This lenticule corresponds to the refractive error of the patient, and this is when this is removed, that leads to correction of the refractive error. Now, this is basically what SMILE is, and as you saw, the whole procedure is done through this small incision that's over here. Basically through this small incision that's over here, thereby the name small incision and lenticule extraction. Now, both SMILE and LASIK have shown high efficacy, predictability, and safety, and that's the reason why refractive surgery has become so popular the world over. It's a bilateral eye surgery being done at the same time, mainly because of the safety of the procedure, and it's become popular basically because this is quite effective and predictable. SMILE may have an added advantage of being flap-free as well. There are three major advantages which are given to SMILE, which are attributed to SMILE. That is, one is that it's flap-free. Second is that it preserves the corneal biomechanical strength far better than LASIK. And third, LASIK. And then third is that it also has a lesser incidence of dry eye. So basically, as we mentioned, SMILE has no flap. It's a cap instead. Since it's a small incision, it's just a cap that's on top of the cornea. So obviously, you don't have any flap-related complications such as striae, dislocation, epithelial ingrowth, etc. You have better biomechanical stability and less dry eyes, as I mentioned here. And if you look at this picture, you'll see that this is the orange is showing a LASIK flap, whereas and this is the part of the cut that's made in the cornea, whereas in a SMILE, the cut is only this much, so it's a small incision. And these two cuts are being shown for an approximate optic zone of 6.5 millimeters. And you can see that in case of RELEX, to get an optic zone of 6.5 millimeters, you have a cap cut of 7.5 millimeters, whereas for an optic zone of 6.5, you would need a LASIK, for LASIK, you would need including the transition zone, the LASIK flap would be about 9 millimeters. And so you can see that the cap cut is also less, which means that the surface over which the cap is cut is about 30% less than that of LASIK. And you also have 80% less side cut. So this part of the cornea is completely uncut. The cut is only this much. So it's 80% less side cut and 30% less cap cut. And these are advantages. When you look at the biomechanics, we'll consider this now in some detail. Basically, what happens is that the anterior, we know this as part of the corneal anatomy, that the anterior and the central stromal lamellae are stronger. And we also know that vertical cuts weaken the cornea much more than horizontal cuts. So the goal of refractive surgery should be to preserve most of the anterior stroma and also to minimize the vertical cuts. And that is what SMILE has as an advantage over Femto LASIK, in that it keeps, if this is LASIK, you see that the anterior stroma is cut, so it's not preserving the anterior stroma, whereas in SMILE, the anterior stroma is being preserved. And this 120 or 130 or 110, whatever is the thickness of the cap that you're using, also contributes to the corneal tensile strength. Whereas in LASIK, the flap does not contribute to the tensile strength of the cornea at all. So that gives you better biomechanical stability. Also, if you look at this picture on the right-hand side, you can see that in PRK, the ablation is in the strongest part of the cornea, which is the anterior cornea. So you're losing some of the strongest part of the cornea, even though you have a good residual or a better residual stromal bed. In LASIK, you are having a flap, which gets, which finally results in some tissue that is not contributing to any biomechanical strength of the cornea. Then you have an ablation below that, which again is removing some of the stronger anterior cornea. And so you're left with more of the posterior cornea, which is obviously weaker in nature than the anterior cornea. So that's the disadvantage of LASIK, that the anterior cornea is where it's quite in a major way involving the anterior stromal layers. Now, if you look at SMILE, the anterior stroma is also left intact and the posterior stroma is also left intact. There's only a small vertical cut in the anterior stroma, and we know vertical cuts weaken it less than the horizontal cuts, and the lenticule is removed from below the anterior less. So this is the reason why it remains stronger. And if you look also at this graph, you'll see that the percentage of tensile strength post-operatively as compared to pre-op is highest with SMILE, followed by PRK, and followed by LASIK. So this was an article by Dan Reinstein, which was based on a mathematical model, which was used to replicate or try to mimic these three surgeries. But when you look at actual studies, biomechanics, there have been multiple studies with multiple conclusions, and we'll just go through these. According to Wang et al., there was a study which said that the corneal hysteresis and the corneal resistance factor, they both decreased more in LASIK-treated patients with myopia more than -6 diopters, and that there was not much difference in these in patients treated for less than -6 diopters. But they did suggest that the cornea after LASIK was generally softer than after SMILE. Though this was non-significant in low myopes, it was significant in higher myopes. There was a study by Dr. Rohit Shetty et al., which basically studied contralateral LASIK and SMILE and used the Corvis ST. And what they said is that the flap and cap cuts induced biomechanical weakening in the patient corneas, both of them, that is, both flap and cap cuts. But the flap cut did cause more weakening intraoperatively. However, the difference biomechanically between the LASIK and the SMILE eyes, or the cap and the flap, were similar after the surgery, which means at 1 week and 1 month, there was really not much difference. Now, there's been another study that was done by Yu et al., which was in 2019, which compared the posterior corneal elevation and corneal biomechanics following SMILE and LASIK, and which is surface ablation, basically similar to PRK. And they evaluated this with the aura. And what they found was that both SMILE and LASIK do change the corneal's posterior surface and corneal biomechanics, but SMILE may have less influence on corneal biomechanics. That means it does leave the cornea stronger at an early stage post-operatively, but in a long-term observation, this difference became less significant. And finally, there was a meta-analysis of SMILE versus Flex, LASIK, and PRK, which basically studied, I think, 22 articles, 22 studies on SMILE and all these other procedures. And they concluded that SMILE was superior to both femtosecond LASIK, while it was comparable to Flex, PRK, or LASIK. That means it was comparable to Flex and surface ablation procedures. Now, there have been other studies, and I'll not go through these because these are ex vivo studies, finite element 3D model studies, and mathematical model studies. So, in conclusion, the meta-analysis did say that SMILE was more superior, though individual studies have stated otherwise as well, or comparable results. And now, if you just look at this graph, this is interesting because it says that to maintain 60% biomechanical strength of the cornea, if you're aiming at that, you can remove about 13 diopters of tissue with SMILE. You can remove about 9.75 diopters with PRK, and only about 5.5 diopters with LASIK. So the minute you remove this much, you're down to 60% of strength, and that is the reason you can also go with higher corrections in SMILE as compared to the other procedures. The other advantage that has been said is less dry eyes, and it's very intuitive because the amount of the corneal nerves that are going into the cornea are cut to a lesser extent in SMILE as compared to LASIK, where the large number of nerves are cut. And so the anterior nerve plexus is disrupted less. So you can see here, this is SMILE versus LASIK, where the anterior stromal plexus is disrupted more. So your dry eye is going to be more post LASIK than, or post flap procedures as compared to SMILE. Also, they did compare Flex and SMILE also, which is again a flap procedure versus a cap procedure, and they found that the central corneal sensitivity was lower with flap as compared to SMILE, both at 1 week and 1 month, whereas in pre-op they were comparable in the patients that were tested. Here is the confocal microscopic pictures of patients who have before surgery, SMILE and LASIK, 1 month post-op, and you can see that there's better recovery post-SMILE. And so there have been, again, a lot of studies which have said that tear breakup time is longer post-SMILE than femtosecond LASIK. So that's an advantage. And that corneal sensitivity has also been higher in SMILE than femtosecond LASIK, which is again an advantage. When you look at efficacy of SMILE, 94% of patients in a study by Hotel et al. Were within ±1 diopters and so on. So this efficacy is also pretty good. Almost 100% of eyes were within ±0.5 diopters in another study. Most of them do give good results, with 99% being within ±1 diopter, 93 being ±1 point. So it's quite comparable to LASIK. When you look at myopic astigmatism, it said that SMILE is safe and effective for correcting high astigmatism. And when you look at high astigmatism, moderate to high astigmatism, both LASIK and SMILE do give you some amount of undercorrection. So you do need to use nomograms in both the procedures, not just SMILE alone. The other advantage that SMILE has is that is something that's important for the surgeon, because the environmental factors are not as important in SMILE as in LASIK, which means your OR environment, which is the humidity, the temperature, all these things, the hydration of the stromal bed, all these things become much less important with SMILE as compared with LASIK. And we know that in LASIK, all of these can be very, very crucial, because with a more hydrated cornea, you end up removing less tissue, or the ablation is lesser. With a dehydrated cornea, your ablation will be more, can result in an overcorrection. All these problems are gone with SMILE. So you don't have to have special nomograms. Your OR need not be under such stringent conditions for the atmosphere as it is post LASIK. Now, when you look at stability, again, most studies have said that it's SMILE patients attain refractive stability by 1 week, and there's no further significant change after 1 month. Optic zone centration is also thought to be comparable between SMILE and LASIK. So overall, it is reasonably good. So now we've talked about all the good things of SMILE. Now, what about the complications? Can SMILE also have complications? We know that LASIK can. Now, both these, I would like to state here at the beginning that both these procedures are extremely effective, extremely safe, with a very good track record and a very good safety profile. But just like in any surgery, you can have complications post LASIK and also post smile. So these are some of the complications that you can get post smile. Here's a patient, and you can see that there was suction loss, just like you can have in femtosecond LASIK. And how you proceed here is again that you reapply, redock, and then recut. And there are various stages at which you can have suction loss. So you can have suction loss during the lenticular cut, during the lenticular side cut, during the cap cut, during the incision. In all these different cuts that are done by the laser system, you can have a suction loss at any of those cuts. And in almost all the steps, you can redock and reproceed with the smile procedure, except only in one situation. That is when the first cut, the lenticular cut, has gone more than 10%. So if there is a suction loss when the lenticular cut has more than 10% but is not yet completed, that's the only situation where you will have to convert to a femto-LASIK, and that in that particular situation you cannot go ahead with smile. Everywhere else you can go ahead with smile. Now the other problem that can happen in femtosecond in smile is again what you see here, black spots, which are basically undissected areas. And you see that dissection in these areas can be more difficult. That was the anterior dissection that you saw. Here's the posterior dissection, and you can see exactly in that area, as shown in the inset, where the black spots were, the dissection is more difficult. So this can be a problem, and this is generally because of the machine parameters. They generally, if you get these, it generally means that the machine parameters have to be adjusted to get better and smoother cuts. And also you need to make sure that there's no tear film debris or things like that which are in between the applinating cone and the cornea, because all of those can also lead on to black spots or undissected areas. Thin lenticules are another thing which can cause a problem and can cause partial loss. The other problem that we'll discuss in the next slide, I'm sorry, but in this particular slide, what we'll talk about is the white ring sign, which I had described and which will be published in JRS and JCRS. And basically, this is very crucial when you start off with smile, because it tells you that you have to, it shows you or it confirms to you that you're doing it the right way. Whenever you do a smile procedure, you always have to dissect the anterior cut first, followed by the posterior cut. So you do the cap cut first, and then you do the lenticular cut. And the reason you do this is so that the lenticule does not get stuck to the cap. So if you do the posterior cut first, what happens is that the lenticule gets stuck to the cap, and then you're not able to remove it. It's much more difficult to remove it. So this, and I'll just pause this video here. This here, it shows that the instrument, so this is what I describe as the white ring. This is the lenticular cut, this ring that you see here. This is basically the lenticular cut of the laser. And if your instrument is above this lenticular cut, it means you're in the right plane and you're doing the anterior cut first, anterior dissection first. And then you will see as it proceeds at this point, and I'll pause again. Here again, the white ring above the instrument, that shows that you're doing posterior cut, posterior dissection. So you can see here that there's a faint white ring, the part of the white ring which has gone above the instrument. You'll see it clearer in another video. That shows that you're doing posterior dissection. So here it's seen very clearly. You can see that this is a lenticular cut. Now this lenticule is lying above the dissecting instrument. So you know that you're doing the posterior cut dissection. So this order of dissection is very important. So it's important to keep your eye on the white ring, and that shows that you're doing the right dissection. Again, you can see this is posterior dissection because the lenticule is lying, the white ring is lying above the instrument. And so this should be done second, only after the anterior dissection is over. The other important thing, as I said earlier, is when you do thin powers. When you do thin powers, there is a possibility of lenticular tear and partial lenticular extraction, which can lead on to irregular astigmatism. So this is again very technique dependent. And if you do it with the improper technique, you can get the complication. So this is a technique which I had described for thin lenticule dissection, which was again published in JCRS. And basically it says that you need to anchor both the edges before you go around separating it fully. So you should not start separation from one side and go on to the, start from here and then proceed to this side, because then you'll have a mobile lenticule, which is very difficult to extract. So keep the lenticule anchored at both in the horizontal meridian, and then dissect it everywhere else, make it free everywhere else, and then only you dissect the horizontal meridia. So here's the video which shows that. This is called the sequential segmental lenticular side cut dissection. So you can see you dissect the lenticular side cut there, then you go from the other side and dissect. And this is important for thin lenticles. Thick lenticles, it may not matter so much. So you've done that. Only in the end do you come to this area, so the lenticule remains anchored, and then you've dissected the entire lenticule and it comes out with, in photo without tearing off. Now, again, rough surgery, as in any surgery, can cause problems. So here's, I'm sorry, my screen just went off. sorry, yeah. So here's some of our trainee videos, and you can see this. This is a rough surgery being done, and this is exactly what I mean by the lenticule getting stuck to the cap. So if you see that, the lenticule has got stuck to the cap there. You see that? And that has caused, this kind of dissection has caused the cap to tear. This is the reason it's always important to do the anterior plane dissection first, followed by the posterior plane dissection, so that you do not get this problem of the lenticule stuck to the cap. And that's why the white ring sign is important. So it's important that you do the anterior plane dissection first, which means your instrument should cover the white ring. And once that is done, only then go and do the posterior plane dissection, at which point the white ring will cover your instrument. So you know the lenticule is now at the right plane. So here what you have to do is now go ahead and dissect that lenticule off the cap, and you can see that the tear is also extending. Now that's important to make sure that the lenticule has been completely removed. This is really rough dissection. As you can see here, the cap was unnecessarily being held, a lot of unnecessary things. But the good point, if you see here, I'm sorry, my video again went off. The good point, if you see here, is despite all that, despite all the cap tear that happened intraoperatively, even by the first day post-op, you can see that it's really, it can hardly be made out. It's very good healing if provided you have replaced properly. So it's something like a flap, a torn flap, or a free cap which has been managed well. So it's similar to that. You've got a good result if you manage it properly. That's the tear. The patient did very well and had 6/6 vision, and that was good. So here's an example of a thin lenticule which is torn during lenticular excess. So this is, I'm sorry, this is again something that should be avoided. You can see that it's always important to examine your lenticule after you remove it to make sure that you have removed it fully. So here you can see this is a partial lenticule. It's not full. You can see the margins, the lenticule, the entire circle is not there. So obviously there's more that has to be removed. So you go back in and you see that lenticule there, and you remove that. That's the rest of the lenticule, and you can put it back together, and you can see that that's like joining the pieces of a jigsaw puzzle together, and you know that you've got the full lenticule that has been extracted. Finally, I'll show you also this complication of epithelial ingrowth. Actually, this needs to be termed as epithelial, yeah, in this case it's epithelial ingrowth, but sometimes you can also have epithelial implants, and this can happen if you're not careful with the epithelium near the incision, because then you can implant it into the space, into the interface, and so you need to be very careful that you don't have any epithelial defects near the incision. So keep your cornea wet and keep your epithelium healthy when you're doing the surgery. Here's an epithelial ingrowth that happened, and this is also basically this case I had treated by using a circle procedure. So that the circle, basically what it does is it converts the cap into a flap. So you can see that this is the cut, this is the sort of cut that you do with the femtosecond laser. So you've converted, and you can see here there's a hinge here. This hinge basically converts the previous cap into a flap. So now what I do is I lift up that part of the a newly created flap and remove the epithelium as you would normally do. Scrape off all that epithelial ingrowth, clean it up, and this is a 9 months post-op appearance of the same patient. You can see doing pretty well. I think of course these are the complications of smile. You also have similar complications in LASIK as well. And what I'd like to say is that every surgery does have its complications, but luckily we are doing refractive surgery, which as such has a low rate of complications, and we are lucky to be in such a field. What we need to learn is to handle the cornea with the respect that it deserves. With that, I'll end my presentation. Thank you so much.
Thank you, Dr. Soosan. Those were very nice videos, and we're going to have a lot of questions. Now, I would like to invite Professor Germán Bianchi, and he's going to be talking on IPCL in presbyopia. Professor Germán, can you unmute and share your screen, please? Yeah.
Okay, thank you. I trying to do that. Okay, it's okay?
Yeah, we can see it.
Okay. Well, good morning here in Argentina. Good afternoon there. I'm really proud for your invitation. I want to thank the Bangladesh Eye Hospital and Institute for this invitation and the committee, the organizing committee, and thank also Istiaki for your kind invitation. Okay, today I will talk about the diffractive facet posterior chamber, IOL, and especially the IPCL for presbyopia. I started with this kind of lens years ago, near to 2017. And in 2018, I started with the second model, the V2, and after that with the model for presbyopia. I don't have any financial interests to disclose. And well, I have this initial result presented the last year. You can find this in PubMed. Dr. Vasavada present the model V1, and I present the first paper for the model V2. But today I will talk about the main characteristic about this lens, for the diffractive lens. It's an hydrophilic polymer with 26% of water. The important thing for me is the overall diameter is from 11 to 14 millimeters, increasing by 0.25 millimeter steps. This is important because we can have more safety for a good bolt after surgery. And another important thing is the standard diameter of the optical is from 5.75 to 6.20, but if we have some big pupil more than 6 millimeter, we can customize from 6.5 to 7.2 millimeter. Another thing is this lens have many holes, one in the middle, and this hole is conic and reduce the light scattering, this kind of hole, and 2 in the upper part of the optical, and also have 6 optic pads, and they are very soft and with some spring effect. And the main important characteristic about the presbyopic lens is this lens works with 50% for far side, 30% for near side, and 20 for intermediate side. And this is a diffractive and refractive lens with trifocal optical design. And this lens have between 5 to 9 rings, depending on the addition. And the addition is coming from 1.5 to 4 dioptrias, but I prefer to use until 3.5. Also have some intermediate addition, and you can see here. And this is another important characteristic. You can see here that the lens always, this lens don't need to rotate because the astigmatism is pre-marked in the lens. And we always put between 0 to 180 degrees. And my indications and tips. The patient with myopia or astigmatism, also you can use with hyperopia, but I never use in these cases because it's a little bit difficult to find anterior chamber with more than 3 and a good angle. 38 to 55 years old without cataract who want glasses independence, and I use the diffractive toric IPCL for astigmatism higher than 1 dioptrias. The first thing that I do is correct the far side with subjective vision, and also taking account the cycloplegical when the patient have more than 15 or 14, minus 14 or minus 15 diopter of myopia. When I correct the far vision, I thinking them for the next 5, 10, 15 years, depend of the age of the patient. When the patient are younger, near to 40s, I prefer my personal formula is like a blend. For the dominant eye, I put the most addition that this patient tolerate, and in the non-dominant eye, I put 0.5 or 1 diopter more. That in this case. But if that situation is not tolerated, I put the same addition in both eyes, but the higher that this patient tolerate. And when the patient have more than minus 10 dioptrias, I choose the higher addition near to minus +3 or 3.5. Well, this is my nomogram or guide to use in this case. I take in account the myopia, the age of the patient, and the 2 options. The option A, the dominant eye and non-dominant eye when this patient tolerate, and the option B, both eyes the same addition. This is my scientific study that I do. Sorry, Okay. This is the inclusion criteria, the exclusion criteria, and the main outcome that I study. It's an prospective non-randomized case series study with 54 myopic eyes with 27 patients to evaluate safety and efficiency of the diffractive IPCR. From February to August, I made these surgeries with 12 months of follow-up. And we can see here the technique that I always do. I start with this technique with ICL from 2016. I made some incision with the B-lance with 20 gauge. And after that, I introduced the irrigation cannula of the bimanual, irrigation aspiration cannula, 20 gauge, and the irrigation cannula is 21. And after that, I made some incision with 2.8 millimeters and inject the lens inside of the anterior chamber. I always prepare the lens before surgery because I need to have this lens prepared before. And after that, with the same irrigation cannula, I put behind of the iris. And I do this surgery just with these 2 incisions. When I start, I did 3 incisions, 2 with B-lance and the main incision just for inject the lens. And it's easy to do because we have positive pressure inside of the anterior chamber. You can see here the presbyopic lens. Okay, you can find more surgeries in YouTube. Okay, the results. The main age was 47, and this study was do it between years 43 to 54 years old. And I am studied endothelial cell density and the corneal central thickness because I did a surgery without any viscoelastic, but we found that any statistical significant difference between baseline and 12 months later just reduced 1.43% of endothelial cell density. The vault was stable without any statistical significance also between safe values. And the IOP, I don't have a peak of IOP in the post-op. And baseline, 1 day, 7 days, 1 month, and 12 months after surgery, I don't find any cataracts in all of the patients. And this is the refractive result. The uncorrected distant visual active was very good, and also the spherical equivalent refractive accuracy. The spherical equivalent attempt versus achieved have the coefficient of determination near to 1. This is important because we can have very good result in this line. No eye lost a line of vision after surgery, and also the refractive astigmatism was very good, with very good result after surgery. This is the average of the binocular defocus curve with very good near side, intermediate, and far side. And we can see here that this is the first lens, intraocular lens, that work together with the crystalline lens, because in this way, the lens near to the 40 have some accommodation also. And in conclusion, the diffractive IPCR model seems to be a very interesting choice for patients in their 40s to 50s. And of course, its efficacy must be studied with a greater number of patients and with a longer follow-up.
Hi, I'm Natasha. I had intraocular lenses implanted the day before yesterday, left eye, and the right eye a week before that. Right now, my vision is very good. I can see from a distance and also close by very, very sharp. I don't see halos. I don't see anything strange. I just do feel I have to adapt to the new situation a little bit, but my vision is very good. And I used to have myopia, -4 or 5 more or less, and I use glasses and contact lenses. So right now I'm very happy I don't have to use them anymore.
And this is some testimony. And here in the down part of the screen, you can see how I charge the lens. and I follow to the end of the cartridge. I don't know why, but I feel safe in that way. And because sometimes the lens rotate, and in this way, I avoid this rotation of the lens. Okay, thanks so much. That's all.
Thank you, Professor Bianchi. That was some new thoughts for us. I am going to introduce our panel, and is my screen? Can you see my screen? Yes. Professor Jafar Khaled, he is the chairman of Department of Ophthalmology in Bangabandhu Sheikh Mujib Medical University, Bangladesh. He is the consultant at LASIK Site Center and Bangladesh Eye Hospital, and he is the reviewer of Bangladesh Journal of Medical Research Council, and he has been awarded the prestigious award in APAO, the Distinguished Service Award in 2018. Professor Brigadier Kamrul Hassan Khan, he is a professor in the Armed Forces Medical College and advisor specialist and head of the department in the Combined Military Hospital. And he is an invited speaker in national and international conference. He has been recipient of the prestigious President Guard Medal Sheba. He is very much actively involved in Bangladesh Glaucoma Society, Bangladesh Society and Refractive Surgeons in different capacities. Dr. Harunur Rashid, he is the associate professor and head of Department of Ophthalmology in Shohid Sarwardi Medical College, and he is senior consultant at Dhaka Eye Care Hospital and LASIK Site Center. And he has received several awards like Professor AQSM Harun Memorial Award. He has got more than 25 national and international publications in peer-reviewed journals, and he is the current treasurer of Bangladesh Society of Cataract and Refractive Surgeons. So with this little introduction, we would go into the question and answer session. I would request Professor Jafar Khaled to start this part.
Okay. Thank you, Ishtiaq, Dr. Ishtiaq Anwar. It was a very enlightening presentation from very eminent 6 local Bangladeshi and overseas presenter. We have so many eminent surgeons who has given us time to elaborate the different aspects of the refractive surgery, and we are really enlightened with this thing. I hope our participants who are listening this presentation will be really, really benefited and will have a wonderful insight about the refractive surgery and the newer dimensions that has been in the research that was previously in the research level, and now it is in the clinical practice. So if I just want to mention some of the points that have been presented by our learned speakers, Dr. Mohammad Rosham. He was really nice giving an introduction in the in doing the pre-LASIK test assessment. I think for any successful surgery, the pre-operative assessment is the most important thing, and he has given all the insights. And it's very interesting that immediately after his presentation, Dr. Rohit Shetty was giving some of the new insights, which will be in the, I'm sure that will be the major considering factor in future. Particularly, he was talking about the tear film optics. He was also giving more importance on the epithelial integrity and health of the epithelium, as well as the integrity of the corneal nerves. So this for this evaluation, he has shown us some images, and this is really a very important part, which will be very important in assessing the preoperative corneal structures. And he was also mentioning about some biomolecular markers, which will be helping us to know about the cornea. So I will just request Dr. Mohammad Rosam from Singapore National Eye Center. Hello, can you hear me?
Yes, I can hear you. Hi.
Hi, Rosam. It's very nice seeing at the Singapore National Eye Center in your background. It is about 25 years back. I was a fellow in this hospital, in this center. So I was working with Dr. Donald Tan and Dr. Chan Wing Kong. I think they are already. And Dr. Cordelia Chan was also a registrar at that time. So at that time, you were at the Singapore National Eye Center was only doing the PRK. Now I understand that this in 25 years, the refractive surgery has changed a lot, and we are in the peak of our technical expertise. I would just, as you have told us about the evaluation, precorneal evaluation, I would just would like to know from you about if you see a patient, say at the age of 21 years, and the topography shows some suspicious keratoconus or the keratoconus suspect or the pre-keratoconus, whatever you say. Do you think that this sort of patient should be kept in waiting for further evaluation in the sense that if you do a repeat pre-operative pre-LASIK test in 2 to 3 years or 1 or 2 years, and if you find that this is not progressing, it's still stable, will it be safe to proceed after a follow-up of this? What do you think?
Well, for me, I tend to be conservative, and I think we are most worried of corneal ectasia. And if you are certain that based on your assessment and your scans that this patient has keratoconus or Forme-Fruste keratoconus, even if you examine them 1 year later, 2 years later, they still have the same features, and this is a risk for corneal refractive surgery. So personally, I will not do any corneal refractive surgery, be it LASIK or SMILE, and even surface ablation. Some surgeons may consider surface ablation with some cross-linking, but only in selected cases if the changes are really, really mild. But I think the main thing is to make sure that, is it an abnormal scan, or is it just a scan which is slightly abnormal? But if the features point out to a keratoconus or Forme-Fruste keratoconus, I would not do any corneal refractive surgery for this patient.
Okay. Even last year, Dr. Rohit Shetty was in Dhaka. He was with us for our introduction of the Vizumax machine, and he was helping us to do the preliminary few surgeries there. And he was mentioning very interesting experience. I think Dr. Rohit Shetty is also here. But my question is to Dr. Rosham, that he was even telling, even after doing a very good preoperative analysis, he has seen 2 to 3 cases of corneal ectasia. There was no evidence of any thinning or ectasia before the surgery. And he has done a retrospective analysis and found that there was nothing was predicting. So is there any other factor which can influence the development of ectasia in these sort of cases?
I think in some cases, even in the most normal scans, there is a risk, which is why biomechanics comes in some. I mean, I think you know that there's a Corvis. We are actually using the Corvis on a routine basis now to examine the corneal rigidity. So even if your scans are normal, it does not mean the cornea is a normal cornea. So there is still a risk. And now with the Corvis, I think we can also eliminate certain patients with normal corneas, but with very soft or less rigid corneas. And these are some of the patients that you may be a bit more careful. So I think a normal cornea scan doesn't 100% eliminate the risk of ectasia.
That's very important.
On all the patients, there's always a risk of ectasia.
Yeah. Is it that the residual stromal thickness which is more important?
Generally, as you know, there is a limit before you cannot go beyond 250. For my case, I do not go below 300 actually for normal LASIK.
Well, we usually set it for 300. Yeah, we will prefer.
Yeah, that's for myself. And of course, in some people, they may even use a percentage tissue altered also as another factor to consider. So I think that there are various things. I mean, the more you laser, the thinner the residual corneal thickness, these are also risk factors for ectasia.
Yeah, thank you. Thank you, Dr. Ishtiaq. I have no more comments.
I would invite Professor Kamrul Hassan. Would you unmute, please?
Can you hear me, please?
We can hear you.
Thank you very much, Dr. Ishtiaq. It's indeed a great pleasure to be a panelist in this wonderful webinar. Actually, we have been observing a series of webinars arranged by Bangladesh Eye Hospital and organized by Iris Division, sponsored by Iris Division for the last couple of months. Though the whole world is fighting against this unprecedented war against this invisible enemy, the COVID-19, but the technology has given us the opportunity to conduct such academic activities. We have been observing excellent presentation from world-class legendary ophthalmologists, namely Dr. Rohit Shetty, Dr. Rosnan, Dr. Soosan Jacob, Dr. Roberto Bianchi, Dr. Ishtiaq, and Dr. Mahajiba. And particularly, I met several times Dr. Rohit Shetty, both in Nara and Netrala, as well as in our country. Dr. Rosnan, if you can remember, probably I have visited SNSC few years back. And usually I used to follow Dr. Soosan Jacob in different international seminars, as well as in the YouTube channels. And definitely wonderful presentation was given by Dr. Roberto and Dr. Ishtiaq and Majib also. A few questions first from my side. Undoubtedly, it is enlightening presentation from all of you. First one is Dr. Roslan. You have shown that contraindication less than 21 years. Is it? Can you tell it absolute contraindication, or you can call it relative contraindication? Because we are doing a lot of surgeries less than that 21 years. And why the female will be preferred? Dr. Rosnan, please.
Okay, so I think age is a relative contraindication. There's no real contraindication with regards to age. Generally speaking, some even do in pediatrics, you know. But I think the main thing about age is really the refractive stability. In general, for us, we take 21 because for most in our population, by the time the patient is 21, about 80% of the patients, their refraction is stable. So I think refractive stability is the most important criteria for us in a sense. You can do LASIK at 18. In fact, we do some.
Yeah, that means it is a relative contraindication. It's yes. Not absolute. And right. Why is the female preference? Why?
Oh, for the female, I think it's just my own anecdotal evidence. If you're doing your first few patients, your first, second, or third, in general, females are much calmer patients. They are less anxious than males. That's what I see. So if you are doing your first case, a female patient usually is a better patient than a male patient. It's not that females are
more tolerant. They're more tolerant, actually.
Yes, they're more tolerant.
Yeah.
And even
I've seen some exceptions. Yeah, there are some exceptions, but generally you can expect a good response from the female patient. Because they're more motivated patients.
Right. Yes, and they're much happier, generally speaking, after surgery.
Sometimes the other way, reverse thing may also happen. Okay, anyway, another thing, Dr. Rohit Shetty, you have been excellently presented the tear film stability, corneal nerve fibers and epithelium, and as well as cell biology and mathematics. Actually, so far we have been doing the pre-refractive surgery assessments in many ways, but these are the things actually, definitely it is there, it had been there, but actually we were not that much very eager to find out all those things. One thing you have shown that some of the cases you found and our conventional topography or pentacam, we found that there was some problem in the topography, but after doing your device, you found that the corneal stroma is absolutely normal. So in those cases, we can go for surgery easily, right?
Basically, over the last year, when we started incorporating the OCT-based topography systems, which looks at the epithelium and the topography together, we started realizing that at least 30-32% of our rejects, direct rejects, are not the true rejects. I'll call it as the pseudo rejects for LASIK surgery. That means you are rejecting them because there is some curvature changes which you're not sure of. And you are calling the patient to come after 6 months and nothing happens after 6 months. All of them, all the composite maps together, you see that the epithelium is actually the culprit, in at least 30-35% of those patients, because epithelium is actually masking a lot of them. In fact, if you see that a lot of contact lens wearers, dry eye patients, eye rubbers, if you sleep on one side, if you're not closing your eyes properly in the night, so interpalpebral region will have an hypertrophy of epithelium sometimes, and that would show us as in pentacam as an curvature elevation, inferior elevation, and you would not want to do a procedures. So in the last 1 year, I have dealt with many of these patients, and we have been successfully doing surgeries, and I've not had any ectasias in the last 1.5 years where I have done surgeries on those patients. The pentacam was not very conclusive, but the stromal mapping was more accurate. So as we move on, I feel that in the times to come, we will probably need more of stromal mapping than a complete with the epithelium. And just to complete my part of the discussion here, in this new lockdown time, you will have virtually everybody will have an epithelial changes because of long hours of work. Any dry eye patients will have epithelial changes. And what I've started noticing is, if you will see a lot of pentacam being completely abnormal in the next few months. That means virtually you will see that they would look very abnormal, and when you really look at their epithelial mapping, you will see that it's because of long hours of work and a lot of other changes on your epithelium. So I think epithelium will have a huge impact in your refractive surgery.
Thank you, Professor Shetty.
Thank you, sir. I had a question for Dr. Soosan Jacob, but the tips for the beginners, how to lift the cuts. She has already mentioned first to cut the anterior and then go for the posterior. The last question from my side, Dr. Roberto, can you please tell those who are having no refractive error for the distance, only for the presbyopia, does it this refractive this presbyopic lenses IPCL hampers distance vision?
Hello.
Roberto?
Yes. No, I don't find any loss of line for far side, and I think, and also the patient that talk with me don't talking about halos or something, or glare, something like that. I think that the crystalline lens that work together with the diffractive lens reduce this kind of defect. I think so.
The patient is not having any refractive error for the distance, only presbyopia, like me. Can I use that?
No. I never use it. I just need to put one of that, but I never use it. No. Sorry.
Thank you very much. That's all from my side, Dr. Ishtiaq. Thank you.
I would invite Dr. Harun. Can you
yes.
Comment for any to any of the speakers?
Okay, am I audible?
Yes.
First of all, I must congratulate Bangladesh Eye Hospital and Institute, particularly Dr. Ishtiaq, for organizing this beautiful international seminar on refractive surgery in presence of a galaxy of stars, ophthalmic stars from Bangladesh and from around the world. And I'm amazed seeing Dr. Rohit Shetty, Dr. Soosan Jacob, and Rosman and others. So it's wonderful listening all these beautiful talks. I don't have any questions, little bit of comments. about I mean, Dr. Jafar Khaled asked about apart from keratoconus possibilities, there are situations where even after surgery, there are situations, as has been mentioned by Dr. Rohit Shetty, nicely, that the new things have come up with MS-39, with epithelial mapping and confocal microscopies, like and also biomechanical analysis by Corvis ST, even collagen fiber analysis by PSOCT, and of course he has mentioned about the molecular biomarkers. So I think, as Dr. Osman has also said about the importance of corneal biomechanics, and also Dr. Soosan Jacob have highly mentioned again and again about the superiority of the smile also, and Dr. Mahaziba has also mentioned about the corneal biomechanical strength, about PRK also. So I think that is the way to move forward. I am using Corvis ST for the last about a year in Dhaka Eye Care Hospital also, and I'm also doing a study between femto-LASIK and the smile, and looking at the Corvis biomechanical analysis. So my question to Dr. Rohit Shetty, that don't you think that by doing corneal biomechanical analysis, because of its sensitivity and the specificity, we will exclude many of our cases, where we could do LASIK or any refractive surgeries, cornea-based refractive surgeries?
Corneal biomechanics at this point of time is a wonderful mathematical tool. I'm using the word mathematical, but if you're using it just to decide or not to decide, I think we have not reached that stage of perfection yet. So it has to use to guide you into what kind of a procedure you do. For example, if your biomechanics is poor, then you would prefer to probably do a PRK, because we have noticed that poor biomechanics is quite forgiving. And if your topography still holds the rules for me, but I would look at the biomechanical assessment as a second option, not the first option.
But if I ask you to compare between the corneal biomechanical assessment and with the stromal thickness and the epithelial mapping, which one you give preference in terms of form first keratoconus or keratoconus suspect?
At this point of time, after using this technologies for a year, I'd put my bet on stromal mapping more than the biomechanics. Okay. Stromal or epithelial mapping.
About the PSOCT? I mean, as you're saying, you are on the process of inventing these things.
It's a wonderful tool, because this will kind of give you a huge addition, because you're going to directly see your collagen fibers orientation. But of course, it will take a longer time for the time for it to actually come into the market. But I see it as the great potential, the huge potential.
Thank you. Thank you so much. So I'd just like to talk to Dr. Soosan Jacob. Madam, good evening, madam. It was a pleasure meeting you at Dhaka and also in India. So it's nice for your excellent presentation on a smile. Definitely, I always follow your white ring sign, and also shimmer sign has been described by Dr. Rohit Shetty also. Just like to ask you about about when you find large angle kappa, how do you manage in cases of a smile?
I think large angle kappa is a thing which is always a little bit of a problem. But myopes, it does not matter as much as in hyperopes. So hyperopes is where you would be really concerned about it. In smile, there's some amount of auto-centration that happens onto the visual axis by the patient, when he looks at the green light. So that is an option that we use. Other than that, I don't know. Maybe I'll ask Rohit about his views on this.
On the angle kappa?
And smile.
Yeah, the big challenge is that at this point of time, I think we'll have that issue coming up when smile goes into hyperopia management. In myopias, these values are not, they're quite forgiving, and one of the major forgiving factor from an optical point of view is a lot of us sitting here have a very small, our pupils are very small, is already a diffraction limited. So your angles don't really have a huge impact. But I think when we when we go into a hyperopic treatment of smile, I think if without an iris recognition or a cyclotorsion compensation, you'll have a huge impact.
Okay, fine. When hypermetropia, we will be able to correct in smile, maybe that time, absolutely correct. But when the myopia, particularly above 1.5 diopter, then we should think about the angle kappa and its compensation. Just like to ask you about, ma'am, about the cyclotorsion compensations in a smile. How do you do that?
So
cyclotorsion
basically, Dr. Sri Ganesh has, and Sheetal Brar, they've published a paper on this, where you can actually rotate the cone, mark the patient's, axis horizontally, the 90 and the 80, 180 and the 0, and then you can rotate the cone so that you can actually get it to align properly, and that can compensate the cyclotorsion. But there's no automatic cyclotorsion adjustment as it's available on the LASIK. I think the new machine, the new machine which is just coming into the market, the Schwind machine will also have cyclotorsion also incorporated into it. Of course, the clinical results are not yet available to see. We'll have to use that and find out how well it works. But basically that's it. As of now, we do a little bit of overcorrection for astigmatism, and that kind of gets us very good results, where the patient is satisfied post-operatively. So there's some nomogram correction that has to be done when you do astigmatism correction as well.
But for normal sphere, do you have any? Do you follow any nomogram for smile?
For spheres?
Yes.
Well, there is a nomogram of how much tissue is to be corrected when you do an overcorrection, slight overcorrection, undercorrection. We do about 10% slightly overcorrection. That's what we do.
I follow that. Yes.
Other than that, basically, there's not much. Astigmatism, I probably would definitely do it in any case, because there's the cyclotorsion component that comes. So because there might be an undercorrection that might happen because of the cyclotortion, I always 100% do a correction for astigmatism.
About the energy optimizations and the spot distancing, particularly in smile, like as has been described by Dr. Sri Ganesh, has said that as the deeper stromas are wider and thicker, so they have spaced, instead of 4.5 for the cap, but for the refractive cut, they have put the spot distance 4.2. So do you think it has some impact on avoiding this opaque bubble layer or this type of spacing and energy optimizations? How does it help?
I think the most important thing about energy optimization is that it has to be optimized for your own machine.
Yes.
It is something that is customizable for every single smile machine.
Each machine is different. Yeah, absolutely correct.
So when you start off and you find too many opaque bubble layers or too many dark spots, you know that there's something wrong with the energy optimization. And with the very first purchase of your smile machine, that is the time when you need to do that energy optimization to get it to the right place where you get that smooth cut, which is that butter-like cut where you just sweep across and it just separates. That is important. And in between, again, if you at any point of time you start getting these opaque bubble layers or difficult dissections, then you need to do this energy optimization again and figure out which is the best spot separation and line separation that is good for your machine, and recalibrate it so that you start to get smoother cuts again.
Thank you, Dr. Jacob. We have some questions. I would like to ask 2 questions from the audience to Dr. Bianchi. That how do you measure white to white? That's number 1. And second thing is that why don't you use OVD, viscoelastic? What is the harm in using OVD?
The white to white I measure with the IOL Master, but I always do the UVM, because sometimes when I found many cysts in the ciliary body, this can reduce the sulcus to sulcum, and it could be a problem after surgery with a big bolt. And the second question is why I started to do some technique years ago without viscoelastic. I started to put the IOL in the cataracts, and after that, I thinking in this way to start to do this surgery, and realized that it's a very safe surgery, and I don't have a peak of IOP after surgery, and I don't have tindal inflammation. And I think it's very good for this kind of surgery, and it's safe also. And I also do I have some technique that I do the vacuum emulsification without viscoelastic, but well, it's good also. But we know that is a friend of us, the OVD, because we need to use, and depend of each surgeons, like you prefer OVD or not, it's a kind of surgery also.
Yes, I have a question to Dr. Roseman, that you have all the machines in your center. So there was one audience, Dr. Ashikullah, he has asked that if a patient has a -3 diopters of myopia and you have all the machines, what are you going to choose?
So, I mean, as you know, -3, if everything's normal, you can actually do LASIK, SMILE, or surface ablation, and they're all good surgeries with good results. I think what you need to discuss is the other factors, the patient factors. Are there any issues with regards to their lifestyle, their occupation? Do they need flapless surgery? Is there any issue with, do they have any dry eyes? These are some of the factors. For most of patients, generally speaking, LASIK should be able to give good vision, very fast outcomes, and is relatively cheaper compared to the other surgeries. However, if the patient wants a flapless surgery, I will go for a SMILE surgery because the recovery is a lot faster, and also there's less of a dry issue. But in some cases, if the eyes are very dry, cornea is thinner, a bit suspicious cornea, then surface ablation. So I think this is how I would decide on the surgery. I will speak to a patient because every patient is different, and no single surgery is. Do
you talk with the patient? Tell them all the options.
Sorry.
Do you tell the patients that these are the options? Which one you want to go?
I mean, since we do all the surgeries, I routinely tell them all the options. I usually don't talk about ICL because unless it's really necessary, because most patients do not really want ICL because of the cost. But if I can't do cornea refractive surgery, I'll speak to them about phakic intraocular lenses. But generally, I speak about the options of surface ablation, LASIK, and SMILE, which we do offer.
Dr. Soosan, regarding hydroexpression of the that lenticule, do you have any experience, or manually?
I think about that paper was published by your group, Rohit, or by Dr. Sri Ganesh, if I'm right. Hydroexpression. I don't remember about that.
No, this was by Jeevan Ladi.
Oh, it was talked by Dr. Jeevan Ladi, I see. Okay, yeah, I think that's a good technique. I haven't really done that, used it myself, because I find it very easy to just dissect normally also. Some of the interesting techniques that have actually been published with SMILE also is for retained lenticular extraction, which is basically OCT guided and also staining with triamcinolone S29. Those are something that I found really interesting about how to remove retained lenticules. I think as long as your energy optimization is good, the SMILE lenticule dissection per se is not that difficult a step. It's relatively simple, as long as you follow certain principles of the anterior cut first, followed by the posterior cut, and you remember when you're dealing with a thin lenticule that it is a thin lenticule and therefore has a higher chance to tear. So your dissection technique has to be more gentle, and you need to be aware of where you're dissecting. There's a lenticular excess technique that can be used to remove that last bit of attachment. As long as you do all these, the SMILE lenticule extraction is really not that difficult.
Madam, any experience?
Hours, it becomes really, really easy because, you know, there's not even a chance of it staring. So that becomes really simple.
Madam, any experience about lenticuloischis?
No, I haven't.
Professor Shetty, I have a question to you that if a cornea is thick enough, you know, and so would you go for a 90 micron or would you go thicker, 130 micron? Cornea permits you to do that. Thick cornea, flap.
You're asking me?
Yes.
The question for me?
Yes.
I'm not a very fond of very thin flaps because very thin flaps has more epithelial remodeling and the epithelium is really quite messier. So my routine flap thickness is 110 microns. The reason is 100 and thicker the flap, the remodeling of epithelium is much different compared to a very thin flap. Even though it gives you that 10 microns of that comfort zone, I think thinner flap, and if you ever have to do a recorrection, if you just take the epithelium of the thinner flaps, you will see that the Bowman's is completely wrinkled. So there's epithelium is you see it in a thinner flap compared to the thicker flap. I think thicker flaps are much more stable. That's what is my opinion on this.
That's great. Dr. Bianchi, there was a question that how do you counsel the patient that, you know, that you have to take it out once the cataract is there? How do you counsel your patients? Can you unmute, please? Unmute, please, Professor Bianchi.
Sorry. Listen now?
Yeah.
Okay. If the patient have cataract, you ask me?
Yes. How do you counsel the patient that after maybe 10 years you have to take it out and again put a lens?
Yes, the extraction of the lens is easy to do, and the calculation of the intraocular lens, I made always before surgery the calculation of the IOL for after cataract surgeries, because I think it's better. But I don't find any change with the intraocular lens or without intraocular lens with for the pseudophakic lens. No, I think I do because I feel safe in this way, but we can avoid it. If you have a patient that you don't see before, you make some IOL master in the same way, and you don't find any problem and any difference.
Dr. Ishtiaq, can I ask one question to Dr. Majiba?
Yeah, please go on. I was also going to ask a question. Can you follow just Majiba? You have said that after 3 days you remove the contact lens. Is that a fixed rule, or you see some signs that epithelialization has happened after PRK?
Definitely, it's not a fixed rule. Usually we remove it after the epithelialization, and usually it takes around 3 days. So that's why I've mentioned it.
I have one question to Dr. Majiba. Can I ask one question?
Yeah, please.
Okay, somebody is having -6 diopter of refractive error. You have got 3 options: LASIK, PRK, and Streamlight. Which one you are going to prefer?
So LASIK, PRK, and Streamlight I'll put in the same category, and then there's LASIK. If for me, if the topography is fine, then I would definitely go for LASIK.
Not PRK, but you have been talking about PRK.
I have been talking about PRK when LASIK is out of the option. That's for me. That's when PRK comes in.
Why not Streamlight?
PRK and Streamlight is pretty much the same. So basically, I was saying because the patient doesn't feel very comfortable after PRK. So if I compare between LASIK and PRK, so my first preference is LASIK for patient's preference. If I have a choice of.
Can I ask you something, Dr. Masiba?
Please.
Up to how many dioptria of myopia do you treat with PRK?
Thank you. This was, I would have asked to Dr. Roseman later, but for us, we do it's maximum of 2 minus 6, but I would love to hear from the other speakers about how much they correct.
So Dr. Roseman, what is the PRK highest limit?
Well, for me, I'm worried about haze, and in the Chinese population, they tend to get quite a bit of haze. I usually try not to do beyond -6, but I have done up to -9 actually in some exceptional cases. But above -6, I'm more hesitant. I will really counsel them about the possibility of haze. Yeah, but I have done up to like -9. I don't think I'll go beyond that, simply because of the fact that the risk of haze is a lot higher.
So this is a question to Professor Rohit Shetty, that some surgeons after lifting it dry the bed, and some will just do it as early as possible. What would you recommend or practice? And
if you're using a microkeratome, your bed is always wet. So if your bed is wet, if you do not dry it, the first few spots of laser goes only to burn out those the dryness, so that you will always get a lot of undercorrection if you are actually having a wet bed. So it is always best to dry the bed, so to avoid any undercorrection. But if you take too much of time, it also creates hydration issues. So enough to wet it, but most of the time when you do a femtosecond based flaps, your bed is not so wet, so you don't have to spend too much of time drying it. The second thing I just wanted to mention about PRK in COVID era, we did some experiment where we found that the ACE2 inhibitors and all the necessary things which is in your oral and lung mucosa, the second most common place in the body is corneal and ocular surface epithelium. So we compared the the lung epithelium receptors of ACE2, which is necessary for the virus to enter. So especially in this time of COVID, when the cases are going up in Asia, we have to be very careful of anything to do with the meddling with the epithelium, because we don't know, because if there is an asymptomatic carrier, and if you have an epithelium, because after lungs, the second most place is the eye, the ocular surface of the eye. Not the, I mean, if there is an ACE inhibitors, it definitely means it can attach itself. So the risk of spread is very high when you are meddling with the epithelium. So PRK should not be one of the major thrust during this time. This is what I feel has to be mentioned. And if you're doing a PRK, I think Streamlight, one of them where you burn the whole epithelium and not trying to dissect it out, would be the better way, because when you're trying to dissect it out, there's always a spill, and epitheliums are small, and aerosols and all this can take some part of it. So anything which does a PTK mode where you're burning the epithelium would have a better risk-free than actually using any form of other form of removal.
Dr. Roseman, you are saying, that assessment, this topography is so important, and usually our technicians are doing it. So how do you know that whether it is a good, they have done it perfectly? And second thing is that in some institute I have seen that they put a drop of lubricants before they do the oculizer. So is it, do you advise that, and how do we know that the test has been done perfectly? Because all the procedure is going to depend on how this test is being done.
Yes, that's true. But in general, if you look at the parameters of your results, if the results are normal, most likely it is normal, right? But if it's a bit abnormal, a bit suspicious, that's when I ask them to repeat it again. Because usually, I think the issue is it's unlikely that if the technician done it wrongly, that they will get a normal result. Usually they don't do it properly, you get an abnormal result. So usually if there's a slightly abnormal result, I'll probably ask them to repeat it. And in general, if in some cases, if I do see some signs of dry eyes, I will ask them to lubricate ask the patient to lubricate before they do repeat the pentacam again. And of course, you have to train your technician well to be able to do the pentacam. For my case, usually if the pentacam is normal, usually it's probably done properly. That's how I assess the pentacam.
Dr. Ishtiaq, may I add something for your question? Dr. Ishtiaq?
Yes, please.
You said about the technician's part. Yes, sometimes there are situations of misalignment. So you can get from the pentacam that people centered the X and Y coordinate. And if you see it is high, then you can take the reading again, because that is the place from where you can get the idea about the high angle kappa also. And there are one more thing important has been added to the pentacam new software. It's known as holiday reports, where they have included the chord mu. You know, the chord mu is normally 0.2. If it is more than 0.3 or 4, then those things are, high angle kappa and multifocal IOLs and all these things we have to think about. So you talked about the misalignment. Yes, you from the pentacam with seeing the X and Y coordinate, you can think about again recapturing the image.
Dr. Maziba, you wanted to ask a question?
Yes, thank you. My first question is to Dr. Roseman. I would like to ask, how much maximum refractive error do you correct with LASIK in your practice?
Okay, so in general for LASIK, if it's above, depending on the cornea thickness, I try not to do LASIK if it's more than 1,000. I will try to steer towards a phakic intraocular lens. However, the limiting factor in my population usually is the anterior chamber depth. So sometimes, in some cases, the anterior chamber depth is not suitable for ICL in some cases, but their cornea is thick enough. I may still consider LASIK. I've done above 1,000, but only after counseling them about the risk. But in general, to answer the question, if it's more than 1,000, I will try to steer them towards ICL. And if the cornea is thin also, I will also steer them towards ICL.
Thank you so much. I have a question for Professor Rohit Shetty. I would like to know that in case of post-LASIK ectasia, so what should be our management protocol?
I didn't get your question.
If there's if we get a case of post-LASIK ectasia, what should be our management protocol?
Many times I realized that in the past, if we get a post-LASIK ectasia, we would jump and go for the cross-linking, or before cross-linking, we used to think of intact, and all this was the norm. But I've realized that many post-LASIK ectasias also are self-limiting if you give them time. So many times they have a tendency to have many post-LASIK ectasia comes to you because they have a lot of dryness, ocular surface issues, allergies, eye rubbing, sleeping on one side, multiple things. So we have managed a lot of post-LASIK ectasias by taking care of them. For example, if there are a lot of dryness, we start them on cyclosporin, Restasis. We ask them to reduce the eye rubbing, decide which sides they sleep on, how you would manage a keratoconus. And sometimes women who have ectasias suffer from PCOD, which are not been treated, or thyroid for that matter. So I've had many patients where systemically, if you're able to treat them, both systemic condition as well as the ocular conditions, you can actually observe them. And there are many post-LASIK ectasias I've been managing last 3 to 4 years without the need of cross-linking or any treatment. And refractively, you can manage them with contact lenses. At least, what I would suggest is at least give them at least 6 months time to see if it's progressing. And if it's not progressing, then if it's progressing, then of course you can do a cross-linking. It's a very inferior ectasia, then intacts would do well. And Dr. Soosan has spoken about the using the corneal tissues, and she's published. It's quite a very, very well-known publication in JCRS. And there are a lot of methods. But what I'm trying to say is that methods, there are plenty, but I would waiting is a big option in post-LASIK ectasia. You don't need to get worried about it's going to progress and you lose the eye. They don't progress that fast.
Thank you so much. I have a question to Dr. Soosan Jacob. Actually, it was related to keratoconus, so I'll shift a little from refractive right now. We have a patient. He is progressive, but his corneal thickness is 350. But his vision is pretty good. It's still 636. So how would you manage this patient?
Few questions first. Is this 350 with epithelium? Obviously on the pentacam or something, right?
Yeah.
Okay, and how old is the patient?
Patient is 26 years.
And this 636 is best corrected or uncorrected?
Uncorrected.
Uncorrected. And he's best correcting to?
Two are lined down, so it comes to 24 max.
Okay. 624. So since he's progressive and he's not, his obviously his visual quality is poor because his uncorrected is 624 and his best corrected is also improving only by one line. That's only 624. And he's progressing. So I would possibly combine a couple of procedures here. I would do CARES, which Rohit just mentioned. That's a technique of using allogenic stromal segments, CAIRS, corneal allogenic intrastromal ring segments, which is similar to Intacs, but it's more like a peripheral, mid-peripheral keratoplasty, mid-peripheral lamellar keratoplasty, I would say. Takes away all the disadvantages of DALC and, full thickness keratoplasties or deep anterior lamellar keratoplasties while retaining all the advantages of Intacs and makes it a much less invasive procedure. Depending on the type of the cone, whether it's eccentric, inferior alone, or it's a symmetric bow tie or a asymmetric bow tie, or depending on all those factors, the type of CARES that is implanted could be customized to some extent, and that would give an improvement in the best corrected visual acuity and would improve his visual quality. Now, once you've done that, you also want to arrest the progression. So since it's 350, it's thin cornea, and when you remove the epithelium, it will come down further. So depending on the epithelial mapping, if there's a conical protrusion, it's possible that the epithelium there is a little thinner, so it may come down to, let's say, 330 pure stromal, or if the epithelium is still 350, approximately 50 microns, it would come down to 300. And we know that doing a plain cross-linking at that level is going to cause endothelial damage. So in this case, I would combine it with another technique of mine, which is contact lens assisted collagen cross-linking. I would place a riboflavin soaked contact lens on top of the cornea, UV-free contact lens. So the one that we use is Bausch & Lomb soft lens, which is made of Hilafilcon, and soak that in riboflavin for half an hour, and then put that on the patient's cornea and do a cross-linking also simultaneously. So that would be my approach, which actually we have done a lot of patients, and they're doing extremely well. And now this is also being done, I'm very happy to say, around the world. There's a center in US which has done 50 CARES, which is a large number. They're very, very, very pleased with their results, and their first paper on technique modification has already been accepted for publication, and they should soon be coming out with their follow-up results. It's also being done in many other countries now around the world, so it's actually gaining in popularity quite a bit. Even CSXL has now got a lot of publications from multiple centers around the world, which I'm happy to say, which have shown its efficacy for thin cornea cross-linking.
Thank you, Dr. Soosan Jacob. I think this has been a tremendous session. It's nearly 2.5 hours. So I think we can end. But last question to Dr. Bianchi or all the panelists. One of the doctors, Dr. Salvo, has asked that he has a patient who is ophthalmologist, 40 years old, with everything perfect anterior segment, and has a refraction of -2 and -1. And has 40 years, so presbyopic, corneal thickness is 535, no dry eye, nothing. Would you go for a multifocal diffractive IPCL?
Yes, totally. Yes, I prefer that. I use one of my patients have -2.5, and with the perfect eye for phakic lens, for the posterior phakic lens, and I use it. I prefer use this kind of lens now for people with myopia from -2, -1.5, that want to to take out the glasses. And well, I think it's a very good option. I have very good result with these people, because when I talk with the patient, the expectation is one of the important things. I said, well, you can take out your glasses now, but you start to use the glasses for near vision. And the people say, well, I don't know if I want to take this target. You can do many things, maybe monovision or another things, but I think that this is a very good option for these patients.
So with this, I would like to thank all the speakers and panelists, Dr. Mohammad Rosman, Professor Rohit Shetty, Dr. Soosan Jacob, Professor Germán Bianchi, Dr. Maziba, Professor Kamrul Hassan, Professor Zafar Khaled, and Dr. Harnur Rashid. So thank you all, and thank all our colleagues and audience who have been with us for nearly 2.5 hours. Thank you. So
Thank you very much.
Welcome.
Thank you all.
Thank you. Thank you so much.
Bye.
Thank you so much.
Thank you, Dr. Ishtiaq.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.